Welcome everyone to another special episode of hashtag CR Arthritis, Arthritis Consumer Experts Programming. Today, I'm joined by Dr. Muhammad Mamdani. He's Vice President of Data Science and Advanced Analytics at Unity Health Toronto and Director of the University of Toronto Temerity Faculty of Medicine Center for Artificial Intelligence Research and Education in Medicine. Dr. Mamdani's work focuses on developing and deploying AI solutions into clinical practice. Dr. Mamdani, welcome to our show.
Pleasure to be here. Thank you for having me.
One of the most anticipated sessions at the upcoming annual scientific meeting is the keynote that you're presenting on applied artificial intelligence in medicine, moving from hype to reality, and looking forward to diving in for you to be able to tell our audience and listeners where AI is at right now in medicine in Canada. And maybe just to start off, you can tell us, I guess, some of the examples that come to mind, real world examples where AI is already improving patient care.
Yeah, these are great questions. So many layers to this one. I think there is a lot of interest and it continues to grow in artificial intelligence, but there's also been a lot of I guess, pessimism as well in terms of some of the things that we've seen where AI doesn't work so well. So it's left a lot of folks in the clinical environment to say, well, number one, what is it really? But number two, is it really going to help me or is it just another fad that's going to kind of come and go? I'm from Unity Health Toronto, where we have an AI program that is dedicated to developing and deploying these solutions. And I can tell you, we've deployed over 50 of these solutions. There are a lot of ways they can go wrong. So I can completely understand the pessimism where people say, oh, these things are just hype. But I also have to tell you, if you do it well, there's a lot of upside to these technologies. For example, we have deployed solutions that have resulted in significant reductions in mortality among our patient populations, where the AI monitors our patients and tells us when patients are going to be in trouble. We have deployed AI solutions where we have seen significant reductions in human effort. For example, one of our solutions, our nurses, they were spending 90 minutes a day on this complex scheduling task or assignment task that really they could have used their time better for. And our AI has taken that over, and they went from 90 minutes a day to under a minute. And their error rates in terms of their assignments went from about a little over 20% to under 5%, all by use of AI. There's all sorts of other solutions like AI scribes, for example, that are out there that help physicians. Basically, they take the notes when physicians interact with patients and create their medical notes for them. And the first AI scribe in Canada was actually developed at our shop.
Hmm.
So all these solutions that are out there now, we're starting to actually start to see them being used. Like the AI scribes, for example, are becoming a lot more prevalent. But I believe we're going to see more and more of these AI solutions to help us manage patients better so we can see better outcomes for them.
Now, you also referred that there are some cases that you wanted to talk about that presented challenges or risks when using
Yes.
AI in medicine. Maybe provide us a few of those examples and where these AI-based decisions maybe were not as safe and reliable for the system or for patients.
Yeah, I think with success also comes failure because the failures actually drive the success. The way we position our group at my center is we're innovators, and what that means is when you innovate, you almost inevitably have to fail to learn from them in order to succeed. So I'm going to touch on a couple of failures that we've had where simple things like, for example, we didn't ask the right question or we didn't target the right end user. When ideas come from people who are not on the ground, not seeing those patients, interacting with them directly, those ideas may be wonderful ideas in theory, but the end users may look at it and say, you're living in a different planet. You have to live, or you have to wear my shoes to understand what I go through, to understand what's relevant to me. And sometimes we overlook even simple things like that. And when you have people who are developing solutions who are not in the shoes of those who are doing, sometimes the solutions don't work very well. So I'm going to be highlighting an example where a solution was developed by one specialty that was a bit paternalistic, intended to make the jobs of another type of physician better without consulting with the physician who's actually providing the care for the patient. And it didn't work out well. Another example that I will also give is something that worked out really well for us, but when we tried to actually send it to other hospitals, just the operations and the logistics, it ended up being quite a bit of a mess. So, what can we take away from those learnings? Those learnings are really the AI solutions must need to meet the needs of the people they are serving. And it sounds so simple, but it doesn't always happen. Actually, in fact, many solutions don't meet the end user needs. And the other thing is that when you actually look at an AI solution and try and deploy it externally, there are so many complicating factors that can really result in failure that if you're not thoughtful about it, you're not going to have a scalable solution.
So in the healthcare sector, when we hear about concerns around accuracy and bias in AI models, is that one of the things you're referring to?
That's one of the things, one of many things. So for example, would you like a concrete example? I can maybe,
Sure.
yeah. Yeah. So one of our solutions um, basically tracks all of our patients and it runs every hour and it predicts who's going to die or go to the ICU in the next 48 hours. And it alerts the medical team when there's a high risk. And this is all done in the background through our AI system. We have seen a 26% reduction in unexpected mortality. So these things are helping us save lives. Now, of course, from an academic perspective, you look at it and say, okay, that's wonderful, but is it biased? Well, what do we mean by bias? We've tested it for young versus old, sick versus not so sick. We've tested it for males versus females, but we've done over 20 different bias parameters investigations, and it seems to hold pretty well amongst all of these subgroups. But we haven't done 40, we haven't done 60, we haven't done 100 bias assessments. At what point do you stop your bias assessments? There's over 100 genders. Can you do a bias assessment in each gender segment? You can't because you run out of sample size. It's not practical. Then ethics comes into play to say, well, you haven't done a race assessment. And the response is, you're right, we haven't done a race assessment. Why haven't you done a race assessment? Well, because there's not a single hospital in Canada that collects race data well. So even if we wanted to, we couldn't do a race assessment. And then, of course, ethically, is it ethical to deploy the algorithm without doing a race assessment? And the ethics would say, maybe you're right. Let's take the algorithm down, wait 10, 20 years until we get race data, and let 26% more people die every year. Is that ethical? So the reality of deploying these solutions is that you have to make ethical judgments because it's never going to be perfect. And we can have academic discussions on what is perfect, but we don't live in a perfect world. So some tough decisions need to be made.
I don't think anybody believes that we have that kind of the comfort of allowing a lot of time to pass either because things are changing and developing so fast in this field. I'm
Yes.
wondering if you could, um, we've talked about the hype into reality. What does reality possibly look like five five years from now?
Yeah, I think it's incredibly hard to predict because personally, I believe that we're going to be very aggressive in this space, have a few setbacks that are going to push us back a bit, give us reason for pause, because I do think if used incorrectly, these technologies can really harm patients. Let's assume that everything is wonderful, goes off perfectly, and we're really starting to embrace these technologies. I would say 5 years from now, we're going to have many AI solutions embedded into healthcare practice that will take away a lot of the rote work that we end up doing that we don't like to do or want to do. That will help us make better clinical decisions. That in the background will be running and saying, have you considered this diagnosis? That'll be very helpful for us because we have a million things on our minds. Um, they say the average complex medical decision involves considering hundreds of parameters, and yet the average human can process seven plus or minus two things at the same time. Of course, we're going to struggle and have issues. AI has the potential to help us reduce that cognitive load to make better clinical decisions that will result in better care for patients and better outcomes. So I do see a world where we have many more of these solutions embedded to help us do better.
Finally, Dr. Mamdani, I'm wondering if you could provide our audience with some actual examples of AI in the field of rheumatology and either in terms of treatment optimization, long-term disease management, diagnosis. Are there some applications that you can cite where it's moving the needle in arthritis?
Yeah, I think there's quite a bit of activity, especially in the research space. I'm not sure that it's actually been used as much. I think that's going to be coming soon.
Hmm.
But if we look at the activity in the rheumatology space, certainly we see lots of publications around diagnostics. So, for example, can we use AI to help diagnose systemic lupus or erythematosus? So, yeah, actually, I think we can. Can we actually look at complications or let's say hospitalization subsequent to lupus? Can we predict those? It seems like we can to a reasonable degree with using AI. Can we actually predict response for drug therapies like tumor necrosis factor drugs? Yeah, it seems like the algorithm suggests that we can actually use AI to do that as well. Now, again, these are often in research environments, and we have to be a little bit careful because research environments are wonderful, but they often don't translate into clinical practice. So these are algorithms that hold potential and promise, but we really need to vet them in the real world. We really need to see if they actually pan out in actual clinical practice. And if they do, they can be incredibly powerful.
Dr. Mamdani, thank you so much for walking us through this incredible, fast-changing, complex topic and joining us today.
Thank you for having me. Take care.
We want to thank everyone watching and listening and hoping you can join us for another episode of hashtag CR Arthritis from ACE. Goodbye for now.